Hello, good afternoon. My name is Professor Babar, and I'm going to make a presentation, the title of which is Stroke and Stroke-like Conditions. And so this will entail showing you a PowerPoint presentation, which would probably last for about an hour. And hopefully you will have some questions towards the end. I will now start the presentation and we'll take on the discussions on stroke, TIA, transient global amnesia, and related matters. Hopefully you'll be able to see this presentation. Now, I've had a long background involvement with vascular surgery, and I had become a professor of vascular surgery with a specialty in carotid surgery. The present discussion is likely to involve and be more useful for everyday practitioners who see a variety of stroke-like conditions and stroke and TIA as well. The information has been updated according to NICE, Stroke Association of UK, and SIGN guidelines, in addition to National Institute of Neurological Diseases of USA. So we go on from here now to discussing what we set out to discuss. So how does one define stroke or TIA? Now, a stroke is a vascular condition causing neurological disturbances, and it is something which causes various kinds of pathological lesions, signs and symptoms in the area which is responsible for causing the stroke, which is focal disorders. And also, as a result of this focal brain disorder, there would be distant lesions or signs or symptoms produced. So these would be global dysfunctions. So such a neurovascular syndrome is likely to last for more than 24 hours or may lead to death. Stroke could be of an ischemic origin where the arterial circulation is obstructed, leading to death or near death, which is infarction of neurological tissue, such as brain, spinal cord, or retina, or it causes death or damage irreversibly of the organ concerned. Stroke can also be produced by spontaneous atraumatic hemorrhage, which occurs as a result of vascular bleeding in the neurological tissue, such as the brain, causing a space-occupying mass compression lesion of the brain parenchyma, and this may also leak into the ventricular system. Sorry. TIA, on the other hand, is a sudden onset neurovascular dysfunction caused by a focal blockage of the arterial forward flow of the brain without any detectable infarction of the local tissues, and that the condition resolves in less than 24 hours, affecting brain, spinal cord, or retina. In the late 1980s, I had undertaken some research, publication, and reviews of something which used to be called in those days as transient cerebral ischemic disease. And the subject matter was, does carotid endarterectomy help in this situation? So, what would be the symptoms of transient ischemic attack? Although not all of the components of the lesion show up in every patient, some have some and some have more than others symptoms and signs. But there is a degree of consistency in as much as the next attack of TIA is likely to follow a similar pattern and involve the same neurological tissue. Sorry. It occurs suddenly and it causes local deficits. Generally, TIA resolves within an hour, but it can persist up to 24 hours. If either the lesion or its effects last beyond 24 hours, then it should be called a stroke. TIA can show itself up as hemispheric motor and sensory disorder such as weakness, paresthesia, or hypoesthesia, in addition to defects of speech, collectively known as dysphasia. Involving the posterior fossa and extrapyramidal tissue, it can produce ataxia, nystagmus, tremors, incoordination, and so on. It can cause also embolic obstruction of either the ophthalmic artery or of the central artery of retina, producing amaurosis fugax. Amaurosis is a Greek word causing black, and fugax is a Latin word meaning vision, black vision. No wonder such names were coined, because a long time ago, stroke was supposed to be a condition which is stricken through divine intervention to see more like a punishment. TIA could involve cranial nerve ganglia as well, manifesting in cranial nerve dysfunction, but this would be recoverable within 24 hours. Stroke, on the other hand, is also of a sudden onset of focal deficits in the brain tissues, but it lasts for more than 24 hours in its side effects, compressive effects, and generalized effects. It can affect conscious level, may distort reality, and may cause confusion. It can cause hemispheric symptoms, which are of motor in nature, or it can cause extrapyramidal features such as dizziness, loss of balance, and vertigo. A stroke can also manifest with having involved the Broca's area in the motor strip, with the clot being in the middle cerebral artery, aphasia, which is loss of language, so bizarre words, neologism can occur, dysphasia, where the words are used wrongly, dysarthria, which is a function of damage to the hemisphere in the cortex, which controls various small muscles, which are muscles of speech as well as muscles of swallowing. So we would explain later that when various words are pronounced in a specific way, the brain remembers it. And it's the loss of functions of these small muscles as a result of infarction of the brain caused by stroke, particularly of ischemic nature, which does not allow for the expression of the vocabulary in the way that the person used to make before stroke. Dyspraxia would be inability to undertake useful functions despite having previous memory of it, but the patient is unable to undertake these. Hemispheric symptoms can include sensory alterations as well, such as hypoesthesia, paresthesia, pins and needles, numbness, and so on and so forth. Stroke also affects those parts of the brain which control sphincters. Remembering that the bladder sphincter, that's the internal sphincter, has an active phenomenon. So actively, energy is spent to tightening the sphincter so that there is no incontinence. If the control mechanism fails, then the sphincter may not be tightly controlled or shut as it should be, with the result that it responds to bladder distension. External sphincter may or may not be preserved. Similarly, stroke may also involve, particularly in the hindbrain region, the sympathetic part of the nervous system, which could cause Horner's syndrome, which is ptosis, meiosis, and inophthalmos. The other condition, transient global amnesia, can be best understood when we review the circle of Willis. This is the circle of Willis. So what is the purpose of circle of Willis? Let me just anatomically describe it, and then we go on to the evolutionary compensatory method by which the circle of Willis handles day-to-day injuries, accidents, microclots, and other things. So the internal carotid artery is somewhere here on the right side, and it gives a branch called the middle cerebral artery, which is this one on either side, and an anterior cerebral artery, which is this one. And so it's on this side as well. Now, both anterior cerebral arteries interconnect through an anterior communicating branch. So whichever side has a dominant flow at that time will ensure blood circulation of an arterial nature in this direction, and it will go past the anterior communicating artery from right to left in this way. The middle cerebral artery also has a branch called posterior communicating artery. So the anterior cerebral artery in this area is also called anterior communicating artery. So the upper part of the circle is anterior communicating artery, anterior cerebral artery, anterior communicating artery, and posterior and the anterior cerebral artery or anterior communicating artery here from the other side. Now the vertebral artery on either side joins up together in the base of the neck and produces a basilar artery, which supplies the pons, the medulla here, and also cerebellum in this area. Basilar artery divides into two: posterior cerebral artery on the right side and posterior cerebral artery on the left side. And so the posterior communicating branch of the middle cerebral artery on either side joins up with the posterior cerebral artery. So the circle is complete. So why has nature tried in an evolutionary sense to create a circle of Willis? By way of an example, if there is a blood clot which has gone into the internal carotid artery, the middle cerebral artery, and has got stuck in the anterior cerebral artery or the anterior communicating branch here, then one would feel that the forward flow in that direction will be restricted. And so therefore, if there is a block where this arrow is, then there would be hypoperfusion or infarction in the territory supplied by this area. What then happens is, if such a mechanical block, obstructing block occurs, then if the other side has 1/3 the dynamic systolic pressure of the dominant right side, then remembering that the brachial blood pressure being 120, the cerebral systolic pressure is 30 millimeter higher. So this area will normally be perfused with 150 millimeter mercury pressure, arterial systolic pressure. So if the left side, which is this one, has 50 millimeter mercury systolic pressure, 70 millimeter, 100 millimeter, as long as it is less, as long as it is more than 1/3 of the dominant side, then the blood flow from this side will go in the opposite direction and perfuse the areas which has become ischemic. So therefore, ischemia is prevented. That is the purpose of circle of Willis, and it's very useful because the head is under trauma several times a day, and the circulation is variable many times during the day. Sometimes the circulation increases and sometimes it decreases in its pressure. So that's the purpose of circle of Willis. This is the same thing. So this is the internal carotid artery trunk. That's the middle cerebral artery. And this is the anterior cerebral artery here. And of course, the vertebral, basilar, and obviously posterior cerebral. So the loop is complete. I won't bore you with the prevalence because you know that already. Suffice it to say that with increase in the life expectancy, more people are being affected by stroke or TIA in the UK. 100,000 cases are registered approximately per year in the UK. And the proportion of population affected by stroke, it relates to the overall population of the country. So in England, 126,000, in Scotland, 9,900, and so on. There are 38,000 deaths in the UK per year, where the cause of death is listed as stroke. So every 5 minutes, someone has died. 2 years ago, when the statistics was collected, the common age of developing stroke in males is around 70 and a bit higher in female. As far as the hemorrhagic variety, which is the subarachnoid hemorrhage, 6 to 12 patients would have that out of 100,000 patients per year. And aneurysm by far outclasses everything else. So what happens when someone has a stroke? There is obviously mechanical obstruction, and so it becomes dry or devoid of oxygen or scanty with oxygen. And so therefore, this ischemia occurs in the territory of the artery which had become occluded. So the neurological tissue becomes ischemic. And then the ischemia spreads for a given territory. This is because most of the arterioles behave like end arterioles. So they do not communicate with veins and they do not communicate directly with other arteries. So there's not much or no collateral circulation to compensate. However, if an artery has become blocked and ischemia has resulted, leading to infarction, then the edges of the infarction, which is further away from the clot, would not be as bad as the part of the neurological tissue which is closer to the block. And so the distant periphery of the infarcted area becomes congested, thin, friable, and may leak blood because of thinness and because of episodic increase of the pressure, such as with coughing, sneezing, valsalva, and so on. So ischemic episodes can become hemorrhagic. So as a consequence of stroke, particularly of the embolic or ischemic type, there would be conscious level which would change. There would be confusion, unreality, irritability, and sometimes seizure because of the infarcted peripheral region would act as a mechanical compression to the normal healthy neural fibers or neural tissue. Whatever has led to the development of stasis, hypercoagulability, or manufacture of a clot, those risk factors would also operate in veins, and therefore there would be DVT. Sometimes immobility, obesity, hyperviscosity, and friability of the intima, as would happen with diabetes, alcoholic binges, and vasculitis, would produce stickiness. And so therefore, a stroke is associated with a rising incidence of independent venous thromboembolism, which can lead to pulmonary embolism. A stroke is often caused by atrial fibrillation, dysrhythmia, stasis in the heart, or lesions developed in the less active parts of the heart, such as the valves, which are coated with various kinds of lesions. The appendages of the heart are vulnerable. In the same way, some viscera could be affected as a consequence of stroke because they are not functioning properly. So what would be the after effects or consequences, late consequences of stroke? So there would be hemispheric disorders such as motor or sensory. This may involve the cortex, so therefore hemiplegia, hemiparesis, dysphasia would occur, and it could involve the posterior fossa, particularly in the hindbrain, producing extrapyramidal features such as irritability, increase of tone, tremors, nystagmus, and disorders of balance. So continuing such conditions will lead to falls, spasticity, and contractures. We have already talked about incontinence, which can occur as a consequence of stroke. The communication issues we have already mentioned briefly. Aphasia is loss of language. Dysphasia is distortion of the words said in a different, unintended way. Dysarthria is pronouncing something which is entirely different to the normal of that patient. Dyspraxia is inability to undertake useful intended function, whether it is speech or activity. Pain is sensed mainly because of a heightened sensory element following stroke. It could also be due to mediators becoming excessive, particularly with the um, gabapentin, the improvement being of tricyclic antidepressants, improving this pain suggests that such pains are mostly neurological. So these are neuropathic pains. Many patients get it. Overtense, unintended use of skeletal muscles lead to tiredness and fatigue, but this is unhelped by rest. So further consequence of stroke late would be dysfunctions. So if somebody has right-sided monoparesis, the arm would not function in the usual way that the person had been using. So the opposite arm needs to adapt, and there should be functional changes which need to be done to perform activities of daily living. A stroke can permanently affect the pattern of swallowing. So there will be dysphagia of solids or dysphagia of liquid. There could be dysphagia. There could be feeding and nutritional problems, and there may be dyspraxia. A stroke can also produce sexual arousal, sexual depression, and matters related to such illnesses. There could be visual disorders, particularly when the person has had multi-infarct condition. Stroke is connected to cognitive decline in as much as there are some conditions of cognitive impairment or of dementia which are produced in a different way when someone has recovered from a stroke or has recently suffered from a stroke. Activities of daily living will be difficult to undertake, and that is why 1 in 12 patients who suffer from hemispheric stroke due to ischemic clots end up or prefer to go to the care home because they cannot be easily managed by family. There are social consequences as well. Income, loss of employment, driving, special needs for housing, adjustments, and so on. Some patients develop psychological or emotional problems because they isolate themselves, being embarrassed, not being able to speak or undertake physical activity in public. So what actually causes ischemic stroke? So 85% of stroke is caused by ischemia or blockage. 15% is caused by hemorrhage. So carotid embolization is an important cause of ischemia. So internal carotid artery is a high pressure, valveless, thick artery, and it has a fairly moderate intima. It comprises 3 layers: intima, media, and parenchyma or adventitia. So therefore, as a result of either vasculitis or injury or hypercoagulability, a certain part of the internal carotid artery, particularly within 2 centimeters of the common carotid bifurcation, is more vulnerable. Research mentions that the forward flow pressure in this area is maximal and that there is some turbulence because of the carotid bifurcation. So the turbulence in physiological terms, changes the direction of flow of platelet from the center to the sides. So this axial transmission of platelet brings them closer to the intima. And if the intima becomes more gluey as a result of some early platelet sticking onto it, then it forms a nidus, where more platelets collect, form a plug, and then this develops a base like a pedicle, and the pedicle supplies some nutrition to the rest of the plaque. Plaque is generally avascular in the sense that it requires very little nutrition. It is not perfused by blood which is flowing from all other sides. It relies on a small nutritional supply from its middle. So this pedicle often becomes necrotic because of debris. When it does, the part of the plaque which is sitting, say, like in the volcano, becomes more dry, more brittle, and under the effect of Valsalva or changed pressure, it breaks off. When it does break off, it follows a path. So from there, it will go to the finer branches, and it could choose to go into the anterior cerebral or middle cerebral arteries, just the two, because it doesn't go to the posterior carotid or posterior circulation. Please remember that many years ago it was recognized through tough tests done on macaque monkeys when someone injected micro metal beads into the internal carotid artery and maintained systolic blood pressure in monkeys, that the embolization took place in a particular area. And so if more beads are injected, it would go to the same place. And that is why if someone has TIA of an ischemic nature, embolic nature, which resolves, the next attack of TIA would probably involve the same neural pathway and vascular channels. So the leftover effect could be additive. So therefore, multiple episodes of TIA would lend itself to becoming stroke. And this pattern of following the same path is ill understood and has been given a name of stereotaxis. So subsequent TIAs will follow the same route, cause similar damage. Vertebral embolization is rare, but it does happen. And it happens into the posterior fossa of the brain. And that means in cerebellum, in medulla, in pons, or in the hindbrain. Sometimes when a person who has got normal flow in the cycle of Willis, if he undertakes vigorous physical activities from his arm, then the demand of more flow comes from the subclavian artery. So more blood should go to the arm to perfuse the hypoxic muscles. So where does it come from? So vertebral artery is a branch, first branch of the subclavian artery, throwing forward flow blood to the base of the brain, and therefore it's joining up with the other side to produce basilar artery. So sometimes the needs of the arm are subserved by reversal of blood supply from the vertebral artery down to the arm. This is called a Steele phenomenon. Cardiac arrhythmia, and in particular atrial fibrillation, is the primary source of cardiac embolism. But there could be other factors as well, such as platelets developed on the vegetative parts of the heart valves and through the appendages. Autoimmune disorders producing vasculitis, such as arthritis of giant cell arthritis, lupus, and similar non-cardiac, non-vascular lesions such as rheumatoid arthritis and others may cause arthritis, stickiness, more glue, and more lesions of platelet plugs firing off in the forward flow. The blood could be thicker, such as in ITP, idiopathic thrombocytopenic purpura, or antiphospholipid syndrome, where the coagulopathy itself makes the blood viscous and less active, and so it is sluggish flow. In some conditions, such as vascular migraine, such as those with an aura, if a young woman has that, then we all know that she shouldn't be prescribed combined oral contraceptive because it would add fuel to fire and that she could end up having a stroke or venous thromboembolism. In a fair number of cases, no positive cause can be found, which has resulted in ischemic stroke. And these are examples of old age stroke. Male patients have a greater preponderance than female. So what causes hemorrhagic stroke? So atraumatic spontaneous hemorrhage can occur due to subarachnoid hemorrhage, principally caused by cerebral aneurysms. And the commonest location is anterior communicating artery aneurysm. And some can be caused by arteriovenous malformation, which are historical and developmental. Most causes are unknown, and in that category is white coat hypertension and also someone who has had episodic hypertension with poor control. So in this idiopathic group, which is 10% of the 15% hemorrhagic stroke, trigger factors are common as they are with ischemic heart disease: nicotine, binge alcohol, physical inactivity, lack of exercise, obesity, unhealthy diet. Also, unregulated and uncontrolled anticoagulants such as warfarin, NOAC, DOAC, excessive use of subcutaneous heparin, and some items of food such as turmeric, ginger, and garlic. They act as food-related mild vasculants. So they are like anticoagulants. Instead of asking who knows what is meant by warfarin in technical terms, I will mention that it is Wisconsin Alumni Research Foundation, warfarin. And so coumarin is a well-known cause of hemorrhagic stroke. Sometimes there are arterial illnesses such as dissection, which is an acquired condition. Sometimes midline shift due to meningioma, or if there is bleeding in a benign tumor of the meninges near the superior sagittal sinus, it would obstruct the physiological flow in the superior sagittal sinus, leading to stasis and clots. There could be genetic predisposition, which increases clotting tendencies, such as Leiden C, Christmas disease, and so on. So the triggers or risk factors of stroke would be cardiovascular risk factors, atrial fibrillation being 20%, and valvular carotid, CCF, and myocardial infarction are the others. Those conditions which cause damage to intima, making it more gluey and sticky and adherent because of increased ADP, such conditions are type 2 diabetes, hyperlipidemia, sickle cell disease, antiphospholipid syndrome, and hemophilia, Christmas disease, and many others. Into this category are also Ehlers-Danlos syndrome, which is the hypermobility syndrome with fibrous tissue, Marfan's syndrome, spidery fingers, tall height, sort of effeminate features, and also aortic aneurysm. Tutankhamun's father had Marfan's syndrome, which was Akhenaten, who was the first Egyptian believing in monotheism. He believed in one God, but that God was Sun. The other rare triggers of stroke could be pseudoxanthoma elasticum, von Recklinghausen's disease, obstructive sleep apnea, but more important than others, fibromuscular dysplasia. This is a new research topic, and it is now overwhelming many parts of the world as being the principal cause of renal hypertension. Fibromuscular dysplasia affects two arteries in general, renal artery as well as carotid artery. So it replaces the tunica media with a fibrous structure so that in bends, in branchings, or when the size reduces, the new fibrous artery is unable to cope. If we could, then perhaps I think we should take a little break. We are more than halfway through, and then we'll go on to clinical diagnosis and what is to be done. So we'll now talk about the clinical diagnosis of stroke or TIA. So the symptoms when they began, which site was involved in its reflection, was the right arm weaker or the left arm weaker, or was it the leg? So fluctuation of conscious level, loss of consciousness. It is important to note the time from the family. The reason is that if one wants to bust the clot, either through radiofrequency ablation or through stenting or through other methods, then 1 hour is the time usually when the clot can be fragmented and busted. One should also note from the family and the patient's comorbidities of relevance, such as past history of TIA, diabetes, ischemic heart disease, and what medication the patient is taking from the doctors, and also self-medications. Diagnosis includes conscious level, Glasgow Coma Scale, airway, breathing, circulation signs, blood pressure, pulse rate, and also peripheral oxygenation. This is followed by an assessment of cardiovascular tree, such as heart murmur, clinical evidence of congestive failure, and so on. Neurological assessment in someone who the doctor thinks may have a stroke recently developed requires urgent action, and if the condition is not so urgent seeming, then a 10-minute neurological examination, which would include conscious level, memory, speech, motor functions, sensory functions, reflexes, and then, of course, Babinski uh, and of course sphincters. It does actually take no more than 10 minutes to have a general examination, including some of the cranial nerves as well. The government has tried to improve public education with regard to TIA or stroke and has developed a advertised symbol called FAST. If you see face being dropped, arms not being able to function or lift, if the speech is affected, then this is time to act and call 999 and rush the patient over to accident and emergency. If it does not impact on early transport of the patient to accident and emergency, then ECG and blood glucose are good tests to undertake to exclude hypoglycemia and also ischemic heart disease or myocardial infarction. So what does one differentiate stroke from or TIA from? So there would be hypoglycemia, alcohol binge and side effects, some hallucinogenic drugs such as LSD, marijuana, and related drugs of addiction. If there is incoordination and problem with balance, then it could be something to do with the vestibular apparatus, could be vasovagal syncope or Meniere's disease or BPPV. It should be distinguished from neurological acute conditions such as seizures, acute vascular migraine, multiple sclerosis, infranuclear seventh nerve palsy, spinal claudication, and so on. Head injury, abscesses, encephalitis may behave in the same way as the early parts of symptoms of stroke. Hypertensive encephalopathy is now deleted, it's no longer something to learn about. But Wernicke-Korsakoff B1 encephalopathy is still around, mainly affecting people who have high doses of alcohol and B1 deficiency. Space-occupying lesions, such as benign tumors, such as cerebellopontine angle tumor or meningioma, which has bled within. It should be differentiated from vasculitis affecting brain, giant cell arteritis, and some forms of dementia. So how does one manage suspected stroke in the primary care? All cases which present should be suspected of being stroke unless there is a history of resolution within 24 hours of its onset. And so such cases should be regarded as TIAs because they have recovered within 24 hours of the onset of symptoms. Emergency admission, and obviously this will need appropriate history, list of medication, and also features as you found these in the patient. Anticoagulants should be stopped until bleeding is excluded through CT scans. Airway, breathing, circulation needs to be attended to with oxygen being given. So further management of TIA would be, if it has resolved, then secondary prevention, same as after myocardial infarction, should be provided. and follow up in the primary care and review and recoding in 6 months' time. Information should be shared with the patient and family about the location of a stroke association, which has valuable, useful, practical information in the form of booklets and on the internet for patients and families. Appropriate driving advice should be given. We'll discuss this after a while. And also on some medication. Patient should conduct remaining active without undertaking severe exercises until seen by the occupational health advisor or undergoing rehabilitation advice. Total abstinence from cigarette and vape and alcohol if possible. Red wine does not protect people from stroke. Alcohol is a depressant agent and it compounds the harmful effects of both stroke as well as TIA. With regard to smoking, the Medical Research Council prohibits such tests or research studies which are inherently harmful. So no one would be able to assess a patient with increasing smoking habits to see whether there is progressive damage being done. With smoking, we have become conscious of syndrome X, first shown up in seemingly very healthy people with shift duties, stress, excess sexual activities, such as in pilots. So they would have clinical features of heart attack, and the co-pilots would take over, the plane would be landed, and then the pilot would be transferred to the hospital, and it would be found that his troponin is normal, his angiogram is normal, his ECG is normal. So where did this chest pain, difficulty with breathing came, which went away? The pilot was seated. So it appeared that excess of caffeine works like nicotine, and it does produce an all or none phenomenon in producing coronary vasospasm. Same type of thing happens with the pre-infarcted susceptible arteries in the neck, both vertebral as well as carotid. Appropriate healthy diet, 5 portions on the plate, more of oily fish, salt less than 5 grams, and no saturated fat, and no red wine with the meals. Supplements such as herbal medications, ginkgo biloba is supposed to be something which helps arthritis and also improves obstruction of the arteries. Not good. Ginger, turmeric, garlic are also regarded as food substances which interfere with anticoagulants of other kinds. So follow up in the secondary care. If in the hospital you suspect that a patient has had TIA within the last week, that is within 1 week, you should administer aspirin 300 milligrams plus PPI, unless the patient is already on low dose aspirin, in which case no dose increase is needed. So within 1 week, if the patient you find having recovered from the TIA is on anticoagulants, including NOAC and DOAC, then urgent CT scan should be done to exclude bleeding. And in this case, no formula such as ABCD2 is useful. Clinical approach is best. So if someone who has had TIA, which has recovered in 24 hours, but had happened in the last 7 days, then such patients should be seen by the stroke unit within 24 hours because of the stereotaxis and additive problems and TIA changing over to stroke. The patient should not drive a car until seen by the specialist. Signpost the family and the patient to stroke association. So without testing knowledge, the dark gray area is infarction. The solid white area is bleeding. It's a blood clot. So therefore, ventricles are not displaced. Midline is not shifted. But here the midline is shifted. And there is a dense bleeding which had taken place, possibly as a result of trauma, because the bones are possibly not symmetrical here. So this is an area of extensive infarction, but no bleeding. So it is the edges of the infarction, ischemic infarct, which will probably become hypervascular or congested and may bleed. So how would one treat patients with stroke? So if a patient has ischemic stroke and there is no evidence of bleeding or CT scan, then the best antiplatelet for this patient, unless they have a cardiac dysrhythmia, is clopidogrel and dipyridamole rather than aspirin. And if they are intolerant, then aspirin 75 milligram. Dual antiplatelet treatment can also be given in cases who have quickly recovered and in whom there is no bleeding potential. So aspirin and clopidogrel for 90 days and then just aspirin. Or aspirin and ticagrelor for 30 days and then just aspirin afterwards. Atorvastatin to reduce LDL and other elements of fat by 40%. The safest antihypertensive, since these are older patients, is thiazide, calcium channel blocker, ACE inhibitor, or ARBs. The target would be to reduce the blood pressure down to less than 130. But if the patient is 75 years or more, then the target should be between 130 to 150 and leave it. If a patient has anticoagulants for ischemic stroke, then that should be given when hemorrhage is excluded. If the severity of infarction is extensive or it is happening in too short a time, then for fear of marginal bleeding from the infarcted area, the anticoagulants should be delayed for 14 days for the hypervascular congested area in the periphery of the infarction to settle down. So if someone has cardioembolism, then anticoagulant is best rather than antiplatelets. So you already know this. 4 main types of antiplatelets are aspirin, clopidogrel, dipyridamole, and something else, which is G32B, G2B3A. So plasugrel, when there is inter-PCI being done, that is the best one, but it's fairly active and it can cause bleeding. Same as ticagrelor. Dipyridamole has both antiplatelet and vasodilatory potentials. It is anti-glue, so this is why it is useful. Biologics which are currently being used are epsiximab, eftifibatide, and tirofiban. And these are substances which degrade fibrinogen if it is formed, breaks up fibrin, and also prevents the thrombin from converting fibrinogen to fibrin. So it acts at multi-site level. It also reduces the gluey potential of the damaged platelet in the laminar flow. So antiplatelets in relation to TIA is usually reserved for primary cardiac or ischemic heart disease prevention or secondary prevention. We have covered the grounds here reasonably well. So obviously, this is what we have talked about. And after a stroke, one should manage patients in primary care when there is a care package already produced before hospital discharge, which looks at patients' individual parameters of where the patient lives, what the patient needs, and how the social services can improve patients' welfare. The rehab specialist, similar to the cardiac rehab, should be contacted or should see the patient within 72 hours because he can advise on how much physical exercises to be done and whether the patient needs any supervision. Of course, advice should be given on incontinence, catheters should be avoided, UTI needs to be periodically excluded, same as constipation. High fiber diet, voluminous 2 liters to 3 liters of drinks if the patient can tolerate it. Checking to see if the patient is inhaling food. So swallowing, nutrition, and oral health, if there is a need, should direct you to refer patients to the dentist. Cognitive impairment is easy to detect by the family rather than by the doctor, and memory clinic should be approached. Neuropathic pain should not need anything other than paracetamol or gel, topical gels. TENS machines have a variable success rate. Sexual dysfunctions, mainly in terms of arousal and sustaining sexual activity, may be improved with PDE phosphodiesterase 5 inhibitors, and rather than sildenafil, it is the tadalafil which has more of a success rate as it works for more than 24 hours and has fewer side effects. In hemispheric paralysis, the spasticity and contracture should be prevented by the physiotherapist teaching the family and the patient how to undertake passive mobilization. For activities of daily living, an OT should assess on behalf of the social services whether the person or the patient needs a carer or is lacking in some benefits or some adaptations in the house or adjustments for independent living. Communication is best handled by proper read coding, proper reviews, and also one should have a low threshold of approaching the speech therapist. Lastly, end-of-life care is part of follow-up of the patient. I hope I've not been overzealous in describing at great lengths various teaching elements of stroke and TIA, but I thought it would be best to remember the subject matter if we approached the subject in this way. I may be wrong, and I would, of course, benefit from your feedback. So hopefully you will remain energetic in preventing stroke and in handling people with TIAs diligently. Thank you very much.